All right, so let's try to finish up this section, and I'll move on and we'll do the ENT part 1. Depending on how much I get through, I might push the optho part 1 into the next section, so it may just be on ID and ENT, the test, but we'll play that by ear. Get it? ENT. But we'll see. Anyway, all right, any questions from the last time that we did farm? It's kind of rude to have to leave you guys on Epi Bio and then come straight back to farm. Like, that was poor planning on the part. Anywho, so we're going to continue on, finish up our antibiotics. Up next, we have the fluoroquinolones. You can obviously tell that they're a fluoroquinolone by having the suffix floxacin on there. If you ever hear someone say levofloxacin, I would not trust that person. I know one person that says that. He's a very smart man, but every time he says that, I was like, I don't know about you. I'd say levofloxacin, ciprofloxacin. There's several floxacins that are out there. Very good wide spectrum sort of antibiotics. They will cover a lot of stuff, including many gram positives, many gram negatives, many atypicals. However, what's the downfall of using very wide spectrum antibiotics? Resistance, right? Because they get everything, so you can use it for a lot of stuff, and so it gets overused, especially for a lot of viral illnesses, and then you see resistance. The way these drugs are working by basically blocking the ability for the bacterial DNA to replicate itself, right? So there's a couple of enzymes, one called topoisomerase 2, otherwise known as DNA gyrase. Not really important, you know the difference between those two. And there's also a topoisomerase 4. Basically, what these enzymes do is that they will induce single-strand breaks in the DNA of the bacteria and allow them to unwind, right? Because normally when you have DNA in a very tight, that double helix sort of configuration, you can't have things like DNA polymerase come in and start to read that to do translation and whatnot. So because of this, basically the topoisomerase will come in, causes strand breaks, allow it to kind of unwind itself, and then you'll have the topoisomerase kind of reattach it. What you'll see is that you can have the fluoroquinolones will actually come in and they'll inhibit those enzymes. So one, if it causes the strand break and you can't reattach it, then that's DNA damage being done, which again, if there's enough DNA damage occurring to a cell, what does that cell undergo? Apoptosis, right? Because again, once it says, hey, there's too much damage here, they're just going to cause cell suicide, right? So it'll kill off those cells. The other thing is if you can't cause that initial unwinding to occur in the first place, and you can't really do things like translation, you can't produce new proteins. These tend to be more on the bactericidal sort of standpoint rather than bacterial static, right? What are some examples of bacteriostatic drugs? Tetracyclines. What other class? Macrolides, yeah, also tended to do that, right? Aminoglycosides, actually, even though they also block protein synthesis, they tend to also be bactericidal as well. They're pretty good killers. But things like macrolides, tetracyclines, they tend to be more bacteriostatic, right? So you can't always go off just the mechanism of the drug, but in general, when you think protein synthesis inhibition, you're typically thinking bacteriostatic sort of effects here. Here, however, because you're damaging the DNA to the point where it causes apoptosis potentially, that's where you're seeing more of the bactericidal sort of effects. So this is a drug of choice for several different indications. Typically, we try to hold back on this one if we can due to some of those emerging resistance patterns, but you'll see them used very frequently for things like community-acquired pneumonias, right, where you're worried about things like strep pneumo, you're worried about things like H flu, but you're also worried about atypical bugs like chlamydia multifida, things like that could be potentially causing these infections. With hospital-acquired pneumonias, we can also utilize these. Remember, those are nosocomial infections these patients are getting. Typically, we require higher doses. What do you think that is versus just a typical community-acquired pneumonia? Resistance, right? So sometimes you can overcome resistance by using bigger doses. That's not always going to be a great option because with bigger doses also comes more side effects, right? So because of that, they may limit how much we can actually drive up those doses, as you'll see later on. UTIs, you can use these for UTI. I would not recommend these routinely for UTIs because, again, they're just too broad a spectrum, right? If I have someone who is relatively healthy coming in with a one-time UTI, they've had no previous antibiotics, these are not the drugs for them. These are way too wide-ranging for that. But if it's someone who has a history, maybe they've been on, they have recurrent UTIs, they've come in for a couple of times already, this may be a good option. A lot of times, though, you're going to be going back back and looking at the cultures to see what you've actually grown previously. I cannot stress that enough. If you have someone who's coming in for a recurrent infection, look to see if they've already have cultures done, because that will guide you in what you need to select, right? So if they've already been growing things like resistant E. coli that is going to be resistant to levofloxacin, this is not going to be a good drug for that person, right? So you need to be able to look back at that sort of thing. Sometimes you don't have any information, you have to go off of nothing, but if you can, try to go off previous information. Now, we cannot use moxifloxacin for UTIs. Anyone know why? Not the nephrotoxicity. Typically what you find is that the fluoroquinolones are going to be renally eliminated. The one exception to that is moxifloxacin. That one's going to be entirely metabolized within the liver. That means that if you have a UTI, which is the infection is where? In the urinary tract. If your drug never gets to the urinary tract because it's broken down by the liver, is it going to be all that effective? No, you actually want the drug to get to the site of action. So if I have something that's going to be renally cleared, that's going to be going all the way through the urinary tract, right? That's going to have much higher concentrations than if I was just allowing it to, kind of passively be there just by tissue saturation. So because of that, moxifloxacin is not going to be used for UTI ever. Okay. Some cases of infection. Oh, yes, sir.
How does that work with the renally eliminated? Wouldn't it be broken down in the kidneys and then not be active by the time it gets to the bladder?
So remember, there's a difference between metabolism and excretion. So usually when I'm saying renally eliminated, that just means that they're going to be passed through the urinary tract out through the urine, right? It does not necessarily mean there's a whole lot of metabolism. There's some metabolism, but not a ton like you would see like within the liver. But very good point of differentiation there. Yes, when things are renally eliminated, they're going through the urinary tract. They're going to be eliminated through the urine in those cases, right? So other cases you may see this sometimes used for some skin infections, not commonly. Osteomyelitis potentially. Sometimes these are used as alternatives if the patient is truly like allergic to something else like vancomycin or say for instance like penicillin, things like that. But so again, wide ranges of use, but again a lot of resistance that comes up with this. Okay, so interactions to be mindful of. With oral administration of these drugs, so these come both in oral and IV formulations for the most part, you're going to find that a lot of cations will chelate with the fluoroquinolone that will prevent them from being absorbed. Where do we see this previously? Tetracyclines, right? So the doxycycline will be bound up with things like calcium and iron. Same thing goes for the fluoroquinolones, right? So iron, antacids. So when I say antacids, what does that mean? Like Tums. Most people think of Tums, right? It's just calcium carbonate, basically. So that makes sense why calcium would do that. But things used for kind of occasional GERD symptoms. A lot of older patients will utilize that. Multivitamins, dairy, anything like that will bind that up. And again, you don't know, is it just the drug's not working because the bacteria is resistant, or is it because they're drinking it with the whole thing of milk, and then that is preventing it from being absorbed in the first place? So these are questions you have to ask. Other things. You will see QTc interval prolongation with these drugs, especially if you have someone who has a congenital heart defect that produces a prolonged QT. If you have someone who has multiple drugs on board, that will prolong the QT as well. Okay. Remember any other drugs we talked about that can prolong QT? Macrolides, right? So this is one of those big things you want to be mindful of, is like when something prolongs QT, at least be aware of it, right? Because again, a single drug by itself probably not going to cause a problem if the patient has no cardiac history. However, multiple drugs stacked on one another can be problematic. Okay, so be mindful of that. So this can produce the prolonged QT. Remember how what that mechanism was that caused that? Potassium pump efflux inhibition, basically. All right, so you're preventing potassium from being effluxed out of the myocyte. You prevent that repolarization from occurring. That's what's going to extend out that QT interval there. Good. Another thing, be careful with this drug in elderly patients. This tends to cause some mental status changes. Again, we don't really know the mechanism why that is, but you're going to find that with a lot of elderly patients who have things like dementia, Alzheimer's, etc., drugs tend to send them for a loop in a lot of cases. Certain ones will cause, cases of altered mental status. You may think their dementia is worsening when really it could just be related to the antibiotic we gave them. And that makes sense. If I were to give an elderly patient, a CNS active drug like a benzo, yeah, of course they're going to be altered, right? Because I'm basically giving them, a drug that's directly affecting the brain. You wouldn't think of that with the fluoroquinolones necessarily, but it is something to note, right? So again, elderly patients may not do well with this from a CNS standpoint. And then, as we kind of mentioned, there's some warfarin interactions where vitamin K may not be absorbed very well from the GI tract due to those gut bacteria being killed off. So you may find that the INR may go up in those cases. We'll talk more about that when we get to the heme section later on in this class here. Okay. So anyway, so a lot of overuse, so a lot of resistance. You may find that there's many infections you just cannot use fluoroquinolones for. This is typically going to be in patients where you have a lot of repeat use of antibiotics over time, or if you have kind of inappropriate use of, like, especially like viral infections and whatnot. Yes, sir.
The elderly, is it that you said that it exacerbates behavioral changes, or that it you don't know if it's working because it might be an Alzheimer's patient? I just didn't catch that.
Sure. Yeah. So you don't know if necessarily the patient is having worsening dementia, or is it a case where the drug is actually causing that in the first place? Sometimes it's like, is it a chicken or egg sort of phenomenon? A lot of patients, elderly patients, when they go into the hospital, especially if they have like a UTI that sends them in, or pneumonia or something like that, where they're being put on a fluoroquinolone. Has anyone ever heard of the term sundowning? What is that? Well, the sun goes down, and then their mental status goes along with it, and it's a very sort of it can be very difficult to deal with, because oftentimes those patients are in an unfamiliar environment. They don't know where they're at, and they get very aggressive sometimes. They can be very difficult to interact with. Family members really kind of puts them out as well, because they're like, that's my dad. They're acting totally crazy. What's going on here? And again, you don't know. Is it just because they're in the hospital and it's an unfamiliar environment, or is it because the drugs are administering, or is it a combination of both of them, right? So oftentimes there's going to be some multiple factors at play here, right? But this is one thing just to know. Yes, ma'am. The sundowning or the drug effects? Once the drug is gone, then the effect is gone for the most part. Once it kind of works out of the system, assuming they have good kidneys and they can get rid of it. So you don't have to worry about that once the drug is discontinued. The sundowning thing, usually once you get them into a more, normal environment for them, and again, not every elderly patient experiences this, but usually those that have some sort of dementia, Alzheimer's, etc., like, once they get into that unfamiliar environment, just anything off of their normal schedule really throws them for a loop. That will resolve once they're kind of back in their normal environment, presumably, right? Depending on kind of what their stuff going on is. Okay, that makes sense. But again, these are going to be renally eliminated, except for moxifloxacin, right? So you got to watch for a renal adjustment as well. You have to make sure you're adjusting for that, otherwise you're going to see more of these effects here. So I have an elderly patient who's coming in for UTI and develops into sepsis, and they're hypotensive and the kidneys are underperfused. Now they're not clearing that drug. That also could be exacerbating, say, the CNS effects we're going to be seeing with that. Okay, so just be aware of that. Other issues you can find: collateral damage, as far as going and killing off a lot of normal flora within the body, especially within the GI tract. So C. difficile is going to be a risk here. I don't know why I didn't put this on here, but of course, one of the other big kind of unique side effects you think about fluoroquinolones is what? Yeah, tendinitis and Achilles tendon tears, right? So this is predominantly something that is mostly warned about, especially in pediatric populations, where you worry about tendinitis. This could result in Achilles tendon tears. It has happened before, and other tendons have torn before as well. So a lot of people just say, well, I'm just not going to use fluoroquinolones in the young patients, right, in the pediatrics. We still use it. I mean, we'll use it with some regularity. We like to use other things if we can, but if we have to, we have to, right? And so it's one of those things where you just educate to monitor for these things. So if you notice, like, hey man, my heel is just really sore, and I didn't do anything to damage it, that's something that you should be, hey, you need to call back up. You need to see if maybe we need to take you off this drug altogether. It's not like I take a dose of levofloxacin, all of a sudden my Achilles tendon just goes out, right? It usually is going to be kind of a progressive sort of thing, but by educating them and letting them know that this is a potential side effect, they can at least call you back up and see what they need to do about it, right? So that's another big thing.
Is the moxifloxacin, I know it's metabolized in the liver, does it bind up that CYP?
It does not cause any significant CYP interactions necessarily. Yeah. So anyway, so just going through, and again, you don't need to know the generations of fluoroquinolones as much as you do, say, for instance, the cephalosporins. Those I would definitely spend some time thinking about and trying to know the differences between. But I'm trying to show you the development of the fluoroquinolones and how some of their use has differed over time. So with one of the second generation ones we had, and we don't use the first generation too much systemically. There are some cases where I use it for things like otic utilization and whatnot. I'll talk about that in the ENT section later on. But ciprofloxacin, pretty good one. As you can see here, does not really cover anaerobes, but it gets pretty good gram-negative coverage. Some gram-positives. This will get better as we get later on in the generations, especially with like more resistant strep pneumo, things like that. Will have kind of plus-minus Pseudomonas coverage. So this is one of those things where if you think about, sometimes we'll talk about like respiratory fluoroquinolones. Now, has Professor Q mentioned anything about using Cipro as far as where you would use it, what type of infections? Someone mentioned it. What do you say?
Cipro's above and Moxie's below. No, Moxie's above and Cipro's
Moxie's below, Cipro's below. Yeah, so one of the things, again, you don't want to use Moxie for UTIs, right? So that's kind of what that was getting at when he said that. But he said Cipro, no Cipro above, right? So that kind of means that for pneumonia coverage, you're going to find kind of hit or miss sort of coverage there. Oftentimes, we won't go with Cipro necessarily. We might try to bump it up to something like a levofloxacin. So spotty coverage may get some Pseudomonas coverage. This may be okay for like a UTI with Pseudomonas in those cases because, again, if it's being renally eliminated, the concentrations get pretty high in the urinary tract. They may be okay, right? They may be able to cover any sort of resistance in those cases there. So just something to consider, right? Again, just be aware of the differences between PO and IV dosing. Don't know this for my test specifically, but know to look this stuff up, right? Just because I have a patient who's on, say, IV Cipro in the hospital, I want to switch them over to oral therapy so I can send them home. You need to make sure you're not just using the same dose. In this case here, you would be underdosing them. You'd find that you'd not be able to really eradicate that infection potentially. So you've got to look at your doses between the different routes there, okay? And make sure you're renally dose adjusting. Watch out for that. Then Levaquin or levofloxacin gets a ton of utilization. Again, it has really pretty good Pseudomonas coverage and pretty good gram-positive coverage with things like strep pneumo, especially in those kind of upper respiratory tract infections. This is a good sort of backup if your other agents are failing. This might be a good option here. You'll oftentimes, remember when I said that typically we recommend not double covering for bacterial coverage? Remember what that one exception was I talked about? Pseudomonas tends to be one of those exceptions. So if I had someone who's coming in, say, from the nursing home, history of previous antibiotic use, and I was really worried about things like MRSA, I was worried about things like Pseudomonas. Typically, Pseudomonas I'm going to cover with 2 different drugs. Very frequently, I'm going to use different mechanisms of action, right? So again, if I use something like, say, piperacillin tazobactam, which how did that drug work? Think back to your piperacillin, so you know it's what type of drug? Penicillin. So it's going to work by? Yeah, stopping cell wall synthesis, right? It's going to be affecting that penicillin binding protein. So good. So now I have one drug that's going to be attacking the cell wall to try to kill off those that Pseudomonas, and then I need something that's going to have a complementary mechanism, right? So could I use something like cefepime? Cefepime we know is a cephalosporin. What is the mechanism of a cephalosporin? Cefepime would be maxipime, Same thing, all right? So would you want to use that? Cephalosporins attack the cell wall. Do I want 2 drugs attacking the cell wall? No, you don't actually get any additional benefit out of that, especially considering the fact that they're both working on that penicillin binding protein. No extra benefit, right? I want something with a synergistic mechanism. So, for instance, I can go with something like, say, a totally only gram-negative killer, something like an aminoglycoside. Remember how those worked? Protein synthesis inhibition, right? So we can use something that works on the cell wall and works on synthesis of proteins. So boom, now we have synergistic mechanism. I'm more likely to get a good kill on that Pseudomonas. Or alternatively, I could use something like a cefepime working on the cell wall and something like a fluoroquinolone like levofloxacin that's going to be able to work on that DNA gyrase and inhibit that new DNA transcription, I should say, and all that good stuff, right? So see, this is what goes into when we make these recommendations about mixing different antibiotics together. This is what goes into that. It's deciding, okay, well, do we get synergism from using different mechanisms of action here? Okay. Anyway, again, renal dose adjustment, be sure to watch out for that. And again, used in a lot of community-acquired pneumonias, mainly because you'll get atypical coverage. Again, atypicals are very good for to note as far as coverage goes. So think your macrolides, think your tetracyclines, fluoroquinolones, get good atypical coverage, and then that strep pneumo I mentioned. Moxifloxacin, as I talked about before, has good Pseudomonas activity. You're going to find that it will not be good for UTIs, as I mentioned, because it gets just totally metabolized within the liver. That's mainly the thing to note with this one. You will still see some moxifloxacin being used for other routes as well. And typically when I say anything topical, say like topical routes, that really means anything external to the body. So if I say topical and I'm referring to an ophthalmic preparation, that makes sense unless I specifically say ophthalmic. I may find some otic uses for it as well. So otic meaning in the ear, obviously. We'll talk about those uses in just a little bit later when we get to ENT in a minute. Okay, so just remember I mentioned a complex with cations, so you have to make sure you're not taking it with iron or milk or anything like that. It's going to bind up with it. Some patients will get some photosensitivity interactions where they will need to wear some extra sunscreen, or make sure to cover up when they're outside, etc. Now, as far as CYP interactions go, these do tend to inhibit CYP1A2. This is less clinically relevant than you'll see come up with things that like inhibit 3A4, right? 3A4 metabolizes a huge number of drugs. 1A2, relatively rare that you see this come up clinically, but still you want to check on those interactions. Anytime you're adding on a fluoroquinolone to someone's pre-existing medication list, just run a quick interaction checker. It takes you 3 minutes to do that, and look to see if there's any really potentially dangerous interactions that will come up there. Okay. As I mentioned, QT prolongations, watch out for torsades, especially with other drugs that will prolong QT. And I mentioned the tendonitis there, Achilles tendon rupture. Be careful if it's less than 18 years of age. Sometimes you'll still have to use it, but some people just won't use them at all. Just depends. Other things to note, in some cases, you may find patients, and this is going to be especially with patients who have renal issues, who do not have their dose adjusted. They tend to build up those levels, and they can tend to cause things like peripheral neuropathies, right? You kind of get, usually the longest nerves tend to be affected the most, and you get this kind of stocking glove sort of distribution where the fingertips and the toes tend to be affected first, and that will then travel up, sort of an ascending sort of neuropathy that can happen there. So again, watch your renal function. You can prevent this from occurring there. And then I mentioned the CNS toxicity that can come about. This is going to be better, more likely to occur with like those elderly patients, especially those renal function issues. Okay, so that's it for the fluoroquinolones. Up next, we have Clindamycin or Cleocin. So this one has a very specific use case for it. It will get all gram-positives, very good gram-positive killer. It will also get anaerobes. It will get 0 gram-negatives. Okay, so aerobic gram-positives, and it will get anaerobes. So what use cases could you see for this? MRSA, yep. So MRSA could be covered by clindamycin, absolutely. So a lot of skin infections and things like that, for sure. Potentially enterococcus, I could see that. What else? Okay, yeah. So potentially you could use this for animal bites, right? So again, when I mentioned previously, like we talked about with animal bites, what sort of bugs do you worry about? Anaerobes, right? Stuff coming from the mouth, and what else? Skin flora, yeah, coming from the patient, right? So again, whatever was in the animal's mouth or the human's mouth or whoever was biting the person, and then whatever's on the patient's skin that could be introduced into that wound, right? So we need to cover for gram-positive, we need to cover for anaerobes. It almost sounds like clindamycin is perfectly tailored just to that. Absolutely. Now again, this is a good backup, especially if you have patients who cannot tolerate like an augmentin, right? So using a penicillin, like an aminopenicillin plus a beta-lactamase inhibitor, this is a really good backup. And so very frequently, you'll see this being used as a backup for penicillin allergic patients. Okay. The reason why we don't use this as a first line, I'll talk about in just a few seconds here, are due to some of the side effects you can see with this. Now, again, is this going to cover every strain of MRSA ever produced? No, there's going to be some resistance that can develop to this. So, for instance, if I'm treating, say, an abscess or cellulitis or something coming into the ER, you need to look at things like the antibiogram, because in some places you're going to find Clinda still has pretty good susceptibility for MRSA. Some places you're going to find that it's pretty crummy, right? You're going to find that maybe it only has like a 65% susceptibility rate. That's not really good enough for your patients. You may need to go with something else. So again, this is hit or miss, but typically we'll cover MRSA. Anywho, again, this is also going to be good for toxin-mediated diseases. The one that really comes to mind is going to be toxic shock syndrome. And we know like the clinical scenario you think of with that? Or toxic shock syndrome?
If you leave a rhino rocket in too long.
Okay, so if you leave a rhino rocket in potentially too long, so if you had epistaxis and you had one of those in. More typically what I think about is if a tampon's been left in for too long, those tend to cause toxic shock syndrome. And a lot of it is mediated through release of toxins from the bacteria that's actually causing the infection. So very frequently we'll use 2 different antibiotics. We use something like a ceftriaxone that will cover the actual bacterial infection, but we'll also use clindamycin because this actually will neutralize some of the endotoxins that are being released from the bacteria. It can be very beneficial because that's usually what's leading to the shock aspects of things, and the patient gets very hypotensive. So sometimes you'll see that being used for toxic shock syndrome specifically. Other things, a lot of skin and soft tissue infections, a lot of osteomyelitis. This can also be used for surgical prophylaxis with pen allergic patients, right? So remember, again, with surgery, you're thinking gram-positive stuff coming from the skin. This is a good coverage for that as well. And then, now would this be good to use by itself for covering, say, like an intra-abdominal infection? Why? Anaerobes. So it covers anaerobes, but what's it missing? Gram-negatives, right? So you would not want to use this for a pure gut infection, by itself, right? Because you're missing all those gram negatives that are going to be growing there in the GI tract. You need to use something in combination with it, right? So something like, say, for instance, a ceftriaxone, right? A third-generation cephalosporin gets pretty good gram-negative coverage, right? That'll cover a lot of gut stuff, but it does not cover anaerobes. So by using, sometimes you get some synergy where if you're not really sure what you're going to be covering for, or this is going to be for prophylaxis where an infection hasn't really taken hold yet, this is why you can use some of these multiple drugs. And again, this is not double coverage necessarily. This is just widening out your empiric coverage in those cases, right? So I'm using something that gets really good anaerobic coverage and something that gets really good gram-negative coverage. By using those together, they kind of augment one another. Now, could I get around that and use something like piptazo, right? Piperacillin tazobactam? Absolutely, because that's a really good combination that has good gram-negatives and good anaerobic coverage. But sometimes, because that's a pretty big gun, you want to hold that back and save it for when you really have infections that really need it, right? So in some cases, you'll find that your go-to drug of choice may be dictated based on things like, antimicrobial stewardship and trying to hold back certain things to prevent resistance. Okay, that's just something you might see when you're out there practicing. Other things this could be good for as well is if you ever have a true blue aspiration pneumonia, these tend to be covered as well. There'll be another drug we'll talk about in a second called Metronidazole. Typically, the thing that I always learned when I was on rotations is that as far as anaerobic coverage goes, anything above the diaphragm, Clinda is really good for. Anything below the diaphragm, meaning the GI tract and the GU tract, tends to be better for Flagyl or Metronidazole. We'll talk about that in a moment, though. So if you had an aspiration pneumonia or worried about anaerobes getting into the airway causing an infection, Clinda can be good for that as well. Okay. Now, as far as side effects go, this is one of the biggest ones that's going to cause C. diff colitis. Okay, and that can eventually progress into a pseudomembranous colitis that can develop due to that C. diff infection here. And this makes sense because again, C. diff is what type of bacteria? The anaerobe, aerobe. It's an anaerobe, right? So again, it's going to grow in these anaerobic environments. If I have something that comes along and kills off all the anaerobes in the GI tract, like Clindamycin, and then will then preferentially leave a hole for C. diff to fill, it's going to cause that opportunistic infection, right? So again, many antibiotics can cause C. diff. Clinda tends to be the one you more commonly think of as being associated with. At least most commonly happens with Clinda. So kind of keep that in the back of your mind. Other than that, it's pretty well tolerated, but you will see a lot of diarrhea, and the C. diff is definitely a possibility there. Okay. Okay, another workhorse sort of antibiotic is going to be sulfamethoxazole and trimethoprim. A couple of brand names you may hear for this is going to be Septra and then Bactrim. Now again, this is a combination drug, and this isn't really the same as what we saw with other combination antibiotics, like for instance, piperacillin tazobactam. What's the tazobactam doing for us? The beta-lactamase inhibitor. Is it actually killing the bacteria? Has no antibacterial activity itself. In this case, though, we have two drugs that are working together on different paths or different parts of the same chain, biosynthesis chain, to inhibit bacterial growth. And so again, both of them have antibacterial activity. In some cases, you may see one or the other by themselves, but this one's a very tried and true combination we've been using for decades now. So if you ever hear like Bactrim or Septra, you may hear like a single strength or a double strength. That's basically just referring to the dosage of the two antibiotics you're going to be in here. And again, this is a fixed combination. I think I might have given you like an example of this back when we did pharmacodynamics. We were looking at the drug dosing. Remember, when you're looking at the dosing of this stuff, go based off of whichever component is trying to tell you. And in this case, usually it's a trimethoprim component, right? So if you ever are looking at dosing and it says do 4 mg per kilo per dose of TMP, make sure you're dosing based off the trimethoprim and not the sulfamethoxazole, because you could be over or under dosing pretty significantly based on how you goof that up, right? So again, make sure you're dosing off the correct component. Now, for instance, if I was dealing with like piperacillin tazobactam, which component would I be dosing off of? The piperacillin, right? Because that's actually the business end of the drug there. That's one I want to be using to actually kill the bacteria. In this case, because both of them have activity, the references will find a standard, and you just go off of that. And in this case, trimethoprim tends to be it. I'm not going to test you on that specifically. Just make sure you're looking at it. Because if it comes up like on a prescription assignment or something, you want to make sure you're dosing it appropriately. Okay. And again, I'm going to have that posted up today, so that we'll have about 2 weeks before the test to get that turned in. So that should be up by the end of today. If you don't see that, just come and harangue me or cut my tires or something like that just to remind me. Don't do that really, but anyway. So the way that Bactrim is going to work is that we'll find that this is working on the thymidine synthesis sort of pathway, right? And remember, thymidine is an important nucleotide that gets incorporated into bacterial DNA. basically what we're going to find is that sulfamethoxazole is going to inhibit this conversion of para-aminobenzoic acid, or PABA, P-A-B-A, as what that's shortened up to dihydrofolic acid, right? So basically there's this tetrahydrobutyric acid synthetase, and you don't need to know that specifically, just know that it's preventing this conversion from PABA to dihydrofolate, right? We're preventing the cell from utilizing folic acid in order to produce thymidine and other nucleotides. The trimethoprim component will then prevent that dihydrofolate from producing tetrahydrofolic acid, right? And so again, that's dihydrofolate reductase. And in fact, if you were to look at, and very frequently antibiotics will have similar kind of like sister drugs that have similar mechanisms to cancer drugs that will actually affect human cells. These just tend to be specific for bacteria. This is kind of similar to what methotrexate does. If you remember us kind of mentioning that drug previously, is it prevents folic acid from being utilized, prevents new base pairs from being made, prevents new DNA from being formed, and thus DNA damage, thus cell death eventually, right? And this is nice because even if the bacteria develops resistance by trying to augment one of these pathways, you still have the other drug that can work on the opposite pathway, and you can still get that bacterial activity, or antibacterial activity, which is nice. So that's another benefit to that. So as far as coverage goes, Septra has very good coverage. So we're going to see things like MRSA tends to get covered with Bactrim, which is nice, especially for things like skin infections and whatnot. Strep pneumo will cover. Listeria will be covered by this as well, so it's kind of a unique sort of thing with that. However, it does not cover Enterococcus. So this isn't really good for like GI infections necessarily. You may see some cases of certain like infectious diarrheas may be covered by this, but if you think like Enterococcus, not going to be good coverage for that. From a gram-negative standpoint, it's good because it will cover things like Neisseria, Marxella, Catarrhalis. We actually use Bactrim pretty frequently for certain opportunistic infections for some of our more chronically ill patients. So for instance, we have like CF patients, right, cystic fibrosis. They will become colonized with certain bacteria that normal healthy individuals in the normal respiratory tract don't get ever. So things like Burkholderia cepacia, Stenotrophomonas multifida, these tend to get specific coverage with Bactrim, and so very frequently we're giving them this drug specifically to cover those bugs there, right? Other things, you know, these are other kind of opportunistic infections you may see, especially like in cancer patients or AIDS patients, things like Toxoplasma, Pneumocystis carinii. So very frequently, if you ever see someone who's on Bactrim, say continuously, right, because normally when you write a prescription for an antibiotic, you're writing for a specific duration of time, like 5 days, 10 days, 14 days. If you ever see someone who's on it chronically, usually it's going to be for prophylaxis against an infection from occurring, and very frequently you do that with patients who have poor immune systems, right? So AIDS patients, you know, especially if their CD4 counts below a certain level. You use it for cancer patients who are neutropenic, things like that. And then once their immune system reconstitutes, then you can take them off of it. But if you ever see that, that's usually what it's for. Because typically, what did I say about prophylaxis with antibiotics? Yeah, you see more resistance. You typically don't want to do that. But in these cases here, the risk versus benefits are such that if these patients get one of these infections and they don't have a good immune system to fight it off, they're going to be dead anyway. So this is at least worse the risk in those cases there. So as I mentioned, clinical use of PJP or Pneumocystis jirovecii. Again, this is sort of the updated nomenclature there. We'll use it for both treatment and for prophylaxis in those immunocompromised patients. You'll see Bactrim used a lot for UTIs as kind of a good kind of gold standard. You know, Bactrim DS, 1 tablet, BID. You know, for a UTI, it's very frequently seen prescription there. In some cases, you may use it for respiratory tract infections. This will be better for patients who have shown sensitivity in these bacteria. This is not usually a first-line sort of drug in those cases. And then, as I mentioned, GI infections, usually like traveler's diarrhea, you know, Shigella, things like that will be covered by Bactrim. So those are other good utilizations for that drug. Now, as far as adverse effects go, again, nausea, vomiting, diarrhea, we see that with any antibiotics. That's not anything to note. One thing to note, though, is this hypersensitivity. So you can see a rash associated with Bactrim. Again, some of it can just be photosensitivity, you know, which can be easily enough to be dealt with. However, this can progress into what we call Stevens-Johnson syndrome, or toxic epidermal necrolysis. So two different things. Clinically, they're difficult to distinguish between the two. But basically, this is where you're having very severe skin blistering. You're having the skin starting to fall off. It can be potentially deadly if not caught early and treated very aggressively. So if you hear anything like, you know, hey, I'm getting these new blisters after I started my Bactrim, that's a warning sign. They need to come discontinue the medication immediately, go to an ER, right? And they need to be educated on that, because otherwise they may just think, I don't know, I had a you know, skin infection, all of a sudden got these blisters showing up everywhere. I guess this is just life now, right? They need to know what those dangerous side effects are in order to do something about it, right? So you need to educate on that.
Why would you use Bactrim on traveler's diarrhea if it doesn't have effects on the anaerobes?
Well, for the specific coverage, so if you think something like Shigella or Salmonella, then you get some coverage there, right? So,
A specific case?
yeah, so it depends on the etiology and thinking like, oh, and, it's traveled overseas and they drank the water there out of the tap, and then all of a sudden that's diarrhea. Like that makes more sense than, you had some other sort of etiology there, right? Anywho, some other blood discrepancies you can see here, and again, this kind of makes sense. Megaloblastic anemias. When do you normally get megaloblastic anemias? Yeah, so you have some of these like folate deficiencies, right? So again, we saw that was actually working to prevent bacteria from utilizing folate. There is going to be some cross-reactivity there, right? So again, it's not 100% specific for bacterial cells. It can affect us as well. So again, you can see that. Thrombocytopenia, agranulocytosis, but usually these are pretty rare for the most part. Other things to note, though, is you do want to be careful of some of these CYP interactions here, right? So again, you're going to find that this will cause a CYP2C9 inhibition. Now, this one is a little bit more clinically relevant than that 1A2 we saw previously. Not as big as 3A4, but still worth noting here, specifically because we'll have things like warfarin therapy. Warfarin is a drug, it's an anticoagulant that is broken down by CYP2C9. If I inhibit that, I'm going to have a whole lot more warfarin around, and that can raise up the INR very significantly, right? We'll have things like, hypoglycemia, sulfonylureas. We'll talk about these drugs later in the endocrine section. We'll talk about diabetes later on, but it can worsen hypoglycemia. And then other things like, increasing levels due to that CYP inhibition of things like, phenytoin, rifampin, digoxin. We'll talk about these drugs. It's not important you memorize those specific interactions right this moment, but just know that CYP2C9 inhibition is where that's going to be mediated through. So if I put a question on a test and I say, hey, this patient is on phenytoin. It's a CYP2C9 substrate. Which one of these drugs, antibiotics, is most likely to interact with that to cause supratherapeutic levels? You would need to be able to point out that, hey, Bactrim is the one that inhibits CYP2C9, right? Versus something like, say, for instance, azithromycin inhibiting CYP3A4, right? Or levofloxacin inhibiting 1A2. Those are the things I want you to kind of key in on, okay? Expecting more typing to occur when that happened, but okay, anyway. Up next, we have Flagyl or Metronidazole. This is a pretty good drug for specific circumstances. Basically, its structure, or its mechanism here is going to be working to basically interact with the bacterial DNA. It'll cause some of this helical structure loss and cause increased strand breakage. Not the same as the fluoroquinolones, a different mechanism here, but it will cause strand damage, which will eventually cause enough DNA damage to cause apoptosis to occur here. This one is going to have a very specific use case. It is going to get anaerobes, primarily, gram-positive, gram-negative anaerobes, and then it will also cover parasites. So it's kind of a unique sort of use case for this one, right? So the thing you're going to see this being used for very frequently are going to include things like Clostridium difficile. So if you remember, back to last time we were talking, what was the other drug we said that could be used to treat C. diff? Vancomycin can be used to treat C. diff. Remember the route that we said that you have to use for vanc? PO. You have to use PO vancomycin in order to get C. diff. If you use IV, it's too big to actually cross into the GI tract. It's not going to work. With Flagyl, though, however, you can use either IV or PO. The molecule is able to cross over. It's no problem, right? So if I had a patient who absolutely could not tolerate PO, I could use IV metronidazole and get around that, right? And in fact, for a long time, Flagyl was the go-to #1 drug for C. diff, especially from an outpatient perspective with PO utilization. However, due to resistance patterns, that has just recently changed in the past year or so. And so now vancomycin is actually being recommended. PO vancomycin is the first go-to drug for C. diff, right? So again, these things will change over time. That just happened in the last year. Other things you'll find, metronidazole is good to add with other drugs for intra-abdominal combinations, right? So this one gets the anaerobes, and I can mix it with something else to get the gram-negative. So for instance, I can mix it with something like ceftriaxone. If we have a kid who's coming in for, say, appendicitis, and we are covering them from a surgical prophylaxis standpoint, right? So before they go to surgery, we want to make sure any of those gut bugs don't get out and cause an infection. We will go ahead and cover them with Flagyl, metronidazole, and then ceftriaxone to get those gram-negatives, and then that will work together to make sure that anything that doesn't release out will get killed off. It doesn't cause any infections there, right? So again, picking your bugs or your drugs based on the bugs you expect to run into, based on the clinical scenario. Okay. Anyway, other things to note, as far as side effects go, this one is a unique one. So has anyone ever heard of a disulfiram reaction? Wow your friends with knowledge of disulfiram reactions. So if you're on Flagyl, and again, clinically, I don't know how often this really comes up, because if I had a parasitic infection, or if I was worried about, say, like a sexually transmitted disease that I had, I don't know how ready I am to go out drinking. That's just me, though, right? However, if you happen to be on Flagyl, one of the things you can see is it actually prevents the breakdown of one of the byproducts of alcohol metabolism. Okay, so if you're looking at alcohol metabolism, basically you have the normal ethanol, right? It gets broken down by an enzyme called alcohol dehydrogenase, right? So break it down into this molecule called acetaldehyde. Okay, acetaldehyde is a very bothersome sort of molecule. If it doesn't get broken down by acetaldehyde dehydrogenase, which is what Flagyl blocks, it's going to just sit there and it causes all kinds of things like skin flushing. You're going to get very hyperthermic. You sweat a lot. It almost feels like an allergic reaction that's happening with that. It's very, very, very bothersome. A lot of people do not like feeling that way. So in fact, disulfiram, the original molecule that did this, was used as an alcohol abuse deterrent. You give people this who are alcohol dependents or alcoholics, who are drinking inappropriately. You give them this drug, and they would, whenever they drank it, they would or drank along with this drug, they would get so sick that they didn't want to drink anymore, right? And a lot of nausea, vomiting associated with it. Now, of course, if you think about compliance, how likely do you think an alcoholic's going to be compliant to taking disulfiram? No, not a whole lot of people have that kind of kind of diligence to their treatment. However, you do see this with certain other drugs, and Flagyl is one of those ones. So if you ever hear about someone who's going drinking and they're on Flagyl, you might recommend against that, mainly due to the fact that it can cause a lot of that nausea, vomiting, flushing, all of that, right? And actually, if you ever see some patients complain about the Asian flush, so some patients of Asian descent will get this flushing as well. They actually have a deficiency in acetaldehyde dehydrogenase. So one of my mentors in fellowship was Dr. Kunisaki. So you might imagine he's of Asian descent, and he would not drink around us. There was a very bad incident that occurred one time. I think he had one glass of wine and he got so flushed and he got so sick, he said, never again, never going to happen. So as much as we tried to cajole him into drinking, never happened. But anyway, so again, that's one of those things you may see with certain patients. All right, so anyway, move. All right, so this is one of the last sets of antibiotics we'll talk about today. So Polymixin B and E. Very frequently, you're going to find that certain antibiotics can be used via certain routes very safely. They cause no problems. If they're used via other routes, they can be very, very problematic. This is one of those categories here. So Polymixin E and B, you'll oftentimes see these being used in topical preparations, right? So if you look at something like a Neosporin, right? A Neosporin is usually a triple antibiotic, usually something like gentamicin, neomycin, and Polymixin B, or neomycin, I should say, and Polymixin B. It's usually a combination of 3 antibiotics. Those antibiotics can be pretty dangerous when taken, say, if you had a big enough dose taken systemically. There's lots of side effects from it. However, if I just apply it topically, you're going to find it really doesn't cause a whole lot of problems. There's very little systemic absorption. They get very high concentrations right at the site of infection. They can kill those bugs very easily. However, there are some circumstances where you need something that the bugs you're growing are resistant to everything, and you need something that's going to, is going to damage the patient, but you got to get rid of that infection because, again, if you lose the patient, it doesn't really matter what the side effects were in the first place, right? So this is one of those sets here, and again, I see this used very sparingly, but it's very good for if you're dealing with gram-negative bugs that are super resistant to everything else. You may use these potentially. And these are kind of interesting because they actually will displace magnesium and calcium within the actual membrane and disrupt it, so that actually will cause cell lysis and cell death here. So very good gram-negative coverage, doesn't really cover much else. However, if you use it topically, it can still get pretty wide coverage because, again, the concentration is just so high, it'll kill pretty much anything. Now, again, we did not use this for a good long time because the toxicities were so bad that the new drugs we had worked way better, less toxic, wasn't really a big deal. And again, we also saw that there was not a lot of resistance developing to these drugs. So even though they retained efficacy, they were just too dangerous for the people who were taking them that we didn't use them for a long time. And so again, you're going to find that you're going to find more usage as we get more of these multi-drug resistant bugs that are developing. I've seen it used a handful of times in the ICU. I remember we had this one patient who I think was somewhere like in the 450 to 500 pound range coming in for pneumonia. And I mean, those patients are just so difficult to treat and to aerate because, again, there's just so much weight on their chest. You'd have to have whole teams of people try to like move them around just to get the lungs to actually aerate again, and they got very nasty gram-negative infections due to being ventilated for so long. And so these are those cases where we have to use something like Polymixin B to try to kill off those bacteria. But problem with it is you're going to see things like nephrotoxicity. These are very, very damaging to the renal tubules. Neurotoxicity causes a lot of things like seizures can develop here, and then also neuromuscular blockade. Basically, when I say neuromuscular blockade, anyone know what that means? means paralysis, basically, right? You think about the neuromuscular junction, right? That was that synapse between the motor neuron with the actual muscle fiber itself that actually cause muscle contraction. Well, a lot of times for patients who are being ventilated and intubated, you have to keep them paralyzed, right? Because that's what's actually going to allow them to kind of synchronize with the ventilator and allow them to oxygenate normally. Well, this can actually worsen that. So even though they'd be working kind of synergistically, where you have a patient who is on a paralytic, you take them off of it, but because they have these drugs around, they would stay paralyzed for a good long period of time. Now, again, of course, they're being sedated as well, so they don't really cognizant of what's going on, but it was a problem because you typically, if you take them off a paralytic, you want them to start moving again, and that wasn't happening in these cases. So pretty dangerous set of drugs. All right, so that's it for the antibiotics. Any questions on those? Again, think the mechanisms, think the unique side effects, think to CYP interactions, drug interactions, you know, as far as like, you know, things like QT prolongation, think about things like, you know, what else, you know, unique interactions like disulfiram reactions, things like that. These are big kind of concepts you want to know. Now, again, am I going to ask you very specifically, does this drug cover Stenotrophomonas multifida? I'm not going to get that specific for this test, right? However, if I say, does this cover MRSA? You have a patient who you're concerned about having an MRSA infection, which one of these drugs would cover it, right? So I'd put penicillin G, I'd put Clindamycin, I'd put gentamicin, and then I'd put something like, what's a good other one? I don't know, azithromycin, right? So you go through and be like, which one of these actually has MRSA coverage? And you go back and say, okay, I know clindamycin has MRSA coverage, right? Those are kind of things I want you to know. Pseudomonas, I'd also want you to know. Those are kind of the big sort of antibiotics, or big bugs that very important that you know which drugs will actually cover that. Similarly, more broad strokes as far as like, does this get gram-negative coverage? Does this get gram-positive coverage? Does this get atypicals? Does it cover anaerobes? Those are big 4 kind of categories you can kind of hone in on. Say, okay, what kind of coverage will I get out of these antibiotics? If that makes sense. Okay. And we'll do during the Kahoot. We'll see more examples of how questions I might ask, and some of the things I think that are important for you to know.
You said you'll have trained engineer teams on this?
Yes, sir.
Together, or like just one of the other?
It's all random, and you guys have to. No, I'm just kidding. No, it'll all be there. So it'll say penicillin, Pfizer pen, or it'll say azithromycin, Zithromax. You know, it'll always say that all there. And again, any test that I review for anyone else around here, I always go ahead and make those corrections anyway, because I think it's good that you at least start to see something consistently. So you may not see that in every class, every test, but at least for mine, you'll see it. Okay, let's do a 10-minute break now. We'll come back and then talk about our antifungals. Any questions from the first half? I just saw that I've only gone 18 slides, and that's a little concerning. But so listen, just some clarification. So those last sets of antibiotics we were talking about, those are kind of one-off sort of drugs, I should say, right? So like the fluoroquinolones, there's a group of drugs that fit within the fluoroquinolones. Clindamycin, there's not really anything that fits in with that. Those are kind of one-offs. Polymixin is kind of a one-off sort of thing. So don't get too confused as far as the classification goes. There are just some drugs that have just kind of a category of one, essentially, right? Other things to clarify, I don't remember if there's any other common questions there. Yeah, that's pretty much it. Yes, sir.
You said that Bactrim and what was it, sulfur? What was the word for it again? Are used interchangeably?
Sulfamethoxazole and trimethoprim.
Septra?
Oh, Bactrim and Septra. Yeah, those are 2 different brand names for the same thing, basically. Right. Yeah, you may see one dosage form being called one brand name than another. It doesn't really matter. Most people call it Bactrim. Some people call it Septra. It doesn't really matter. Okay. So anyways, moving on. Let's talk about a couple of fun guys. Nope. Okay. Anyway, so fungal infections, right? So we talked about how a lot of our antibiotics are very specific for bacteria because they're shooting for targets that are specific to those bacteria. Similarly, you're going to find that with antifungals, they're going to try to shoot for targets that are very specific to the fungus, right? And so typically when you're looking at the fungal cell wall, and very frequently a lot of these drugs here are going to be more specifically targeting the cell wall itself because this tends to be a big component here. They have a pretty rigid cell wall that contains chitin, and so it's composed of several different components, but one of the big ones is called ergosterol. And then you're also going to see some of the other things that will make it kind of unique to the fungus is going to be the different ribosomes, so they'll have different targets there. They have a distinct nuclear membrane that's present there. And again, they tend to be pretty resistant to antibiotics. Okay, so you're going to find, and in fact, a lot of funguses that will actually, fungi will actually release antibiotics, their own kind of custom homebrew antibiotic to prevent other bacteria from growing around it, right? Because again, they're usually competing for the same spaces here, which is why we get penicillins from molds, right? Exactly. So that's kind of the same thing there. So we need specific drugs that are going to be targeting these fungi, right? And so the question is like, well, who typically gets a fungal infection? We spend a lot of time talking about antibiotics because really anyone can be susceptible to a bacterial infection. However, less likely are you to run into actual true blue fungal infections, right? Now, certainly there can be things like, nail infections and things like that tend to be a little bit more frequently seen. However, you're going to find that typically certain patients are going to be more predisposed to having more systemic sort of fungal infections, right? So these are going to be typically people who have maybe lost barriers to protection, right? Because again, our skin's usually a pretty big barrier to infections. So if you have like a burn patient, surgery, they have kind of indwelling catheters and things like that, that can introduce fungus. Typically, immunodeficient patients tend to be more likely to develop these fungal infections. So things like cancer, HIV, organ transplants. Why do you think organ transplants patients tend to be immunocompromised? We have to make them immunosuppressed in order to make sure they don't reject their organs that we just transplanted into them, right? They're on active chemotherapy. Some cases you can have patients have metabolic abnormalities like diabetes. If your sugar's running 300s at a baseline, everything's going to want to grow there. Bacteria, fungus, anything like all that sugar is going to be able to proliferate there. If you have suppression of competing organisms, right? So potentially if I have a patient who is on several courses of antibiotics, that can then kind of leave the ground barren for fungi to come in and actually cause an infection in those cases. That could be one situation here. And then they love moist, warm environments. So if you think about things like diaper rash, athlete's foot, anywhere it's nice, warm and moist, bugs or those fungi tend to want to grow there. Okay. Now again, a lot of these tend to be involving the skin, and you're going to typically find these are going to be difficult to treat. Oftentimes the durations of therapy are going to be pretty long for especially things like nail infections and whatnot. If you think about a typical antibiotic course is how long? Antibiotics 5, 7, 14 days maybe, right? Rarely does it get extended past that unless there's a very specific case. Oftentimes for these fungal infections, especially like in the nails and whatnot, it can be months, right? So treating for 3, 4, 5, 6 months, right, is not unheard of. But rarely they can be systemic, and usually it's going to be one of these really kind of sick patients who is immunocompromised, and it can be very, very difficult to treat, right? And again, what we're going to find is there's a lot of bleed over the toxic effects from trying to kill these fungal cells off to our human cells, and we're going to see that's going to be pretty problematic here in a few minutes. So, and again, I'm not going to get super specific on the different varieties of fungus that can cause infection in humans. You'll cover that in microbio specifically. But some of the things you kind of want to keep on the back of your mind are going to be things like candidal infections, right? You find a lot of candida in things like diaper rashes. You find it a lot causing, what do you call it when it causes infection in the throat? Thrush, yeah, when you hear thrush, that's usually a candidal infection. That can be a sign of immunocompromisation in some patients. In fact, certain drugs can predispose patients to candidal infections. In fact, if you think about things like steroids, right? Steroids typically do, like corticosteroids, typically do what to the immune system? They typically suppress the immune system, right? And in fact, there's a drug that actually I take. It's called Advair. It's for asthma. And one of the cornerstones of asthma therapy is inhaled corticosteroids. And so this drug actually will inhale it, and patients will have that. One of the big things you warn patients about is to make sure you wash your mouth out afterwards, because that corticosteroid can just sit there in the back of the throat when you inhale it, and that can actually cause a candidal infection. So thrush is more likely to occur in patients taking that drug, right? So little things like that you'll learn about as we go forward. But again, and you're going to find that especially with like things like superficial mycoses, so things like hair and nail infections tend to be a different variety of fungus, and we'll see that the drugs will change a little bit what you're going to use for those. Okay, so again, this is just kind of a very brief cursory survey of different antifungal agents. We'll talk about these more specifically when we get into the specific organ system. The overview of the different drugs we're going to have available to us here. These are the different categories. We're going to go over these very specifically. You can refer back to this as needed to get the different categories down here, as we'll see. So typically, as far as mechanisms of action go, a lot of these drugs are going to be attacking the fungal cell wall. For instance, the polyenes are going to be able to affect the membrane integrity and permeability by basically preventing ergosterol synthesis. I mentioned ergosterol is a big component of the fungal cell wall. If you prevent that from being formed, you break down the integrity of that fungal cell wall, lyses out the content. Very similar to what we saw with a lot of cell wall active agents like we did with penicillins, cephalosporins, carbapenems, all those sort of things. Other things, azoles are going to be working on the same mechanism via a different pathway. In this case, you're going to inhibit this lanosterol demethylase, which will decrease ergosterol synthesis. For your purposes, just know it's decreasing ergosterol synthesis is going to decrease increase that permeability of that fungal cell wall, right? The integrity goes down. The allylamines will work on a different enzyme. So again, different mechanisms to basically get to the same point where you're decreasing that ergosterol synthesis. Other things, you can have things like the echinocandins will be working on inhibiting the D-glucans that actually are in the cell wall formation. I should specify this is the cell membrane versus the cell wall. Again, clinically, you're not going to doesn't really make a whole hill of being a difference for our purposes, but they'll have a little bit different activity here. In this case, it works on the cell wall with the echinocandins. Some of these will be working on actual cell division. So you remember the microtubules, where do they come into play when looking at cell division? Remember back to mitosis. They pull apart those chromosomes, right? Those little microtubules will pull things apart. They provide cell structure to the fungus as well. We'll see the griseofulvin. This is a very common one used a lot in urgent care for a lot of different fungal infections. You're going to find this one is working to actually inhibit the microtubules. If you can't have mitosis, the cells cannot continue to reproduce, right? And then in some cases, we'll do things like affect nucleic acid synthesis. So, for instance, you have something like flucytosine will actually be converted to this drug called fluorouracil, and it will prevent things like thymidine from actually being formed. So again, prevent DNA from being formed. You prevent the actual cell from producing new DNA. All right, so another one we have here, this one drug called amphotericin B. Oftentimes people will call this amphoterrible B because of the side effects are so bad on this one. This one's kind of interesting because this actually will form channels in the membranes. So basically you can find the ergosterol sitting here within the cell membrane. If you have amphotericin B coming, it'll actually form this nice big pore. And you kind of can see that if you look at the structure there, it has this kind of like a blade sort of function or sort of structure where you can imagine just kind of piercing right through that cell membrane. And that allows things like potassium and magnesium to leak out of the cells, and that causes damage to the membranes, eventually causes the cell death. Now again, you're going to find there's going to be some bleed over as far as effects go to with human cells. So imagine if this happens to your human cells, this could also be problematic, and that's what we're going to see, especially with the kidneys here in a minute. So amphotericin B, very, very bad drug from a side effect standpoint. I'll show you why in just a moment, some of the things that can cause. But this is actually kind of an interesting thing from a drug standpoint of ways that we can actually mitigate some of the side effects. Now, amphotericin B is a very good drug. It'll kill off basically any fungus you find, but it's probably going to do some serious damage to your patient as well. One of the ways they got around that, one of the ways they tried to change the dosage form to try to prevent damage is by actually introducing this liposomal complex. Right, so if you remember back when we were talking about phospholipid bilayers and all that, this is basically what that is, just a phospholipid bilayer. And if you'll notice, the drug is actually impregnated within this membrane, and for whatever reason, they found this actually causes a lot less damage to human cells while still being effective against the actual fungal cells itself. Now, because of that, because they have this nice fancy dosage form, guess what it does to the cost? It jacks it up pretty significantly, right? So much, much more expensive, probably 20 to 50 times the amount of money it costs just for that compared to the conventional amphotericin B. But if I don't have to put my patient on dialysis because of toxicity, that's probably going to be worth it in the long run, right? So again, it's very kind of interesting, but something you have to keep in mind as far as like cost goes, risk versus benefits and all of that. So if you ever see like liposomal or the colloidal suspension, that's basically what we're talking about with that. That's all the different forms of the same drug, amphotericin B. So again, I'm not going to ask you specifically which fungus this is going to be used for. I just kind of want to give you an idea of what you're going to see, what sort of different funguses that it can cover. Things like aspergillus, that's another big one you want to at least keep in the back of your mind as far as like very significant invasive sort of fungi once those infections take place. But Candida, as we mentioned before, is a big one. We typically reserve this for more invasive infections. So if you get like a fungal pneumonia or bloodstream infection or something, this is where these amphotericin gets pulled out. Now again, as far as the side effects go, you can see a lot of fevers and chills associated with this, oftentimes because it's actually releasing things like interleukin-1 and tumor necrosis factor. We know those are important sort of inflammatory cytokines that get produced during the inflammatory cascade. Oftentimes we have to treat with things like Tylenol, give them antihistamines and corticosteroids to try to prevent that. So we can try to pre-treat them a little bit to prevent a lot of the fevers and chills and myalgias that come along with all that TNF and IL-1 release. Other side effects here, as we mentioned, with the electrolyte abnormalities, it's very easy to see how that could occur because, again, with it causing release of things like potassium and magnesium out of the fungal wall, it's actually going to do the same thing, especially within our renal tubules. And so you can find they're going to pee out a lot of hypokalemia and hypomagnesemia. We call this electrolyte wasting. When you end up peeing out a lot of electrolytes you should be holding on to. You see hypotension, uremia, and very frequently being caused, also causes decreased filtration, so your GFR will take a hit. And I mentioned causing pretty significant renal tube damage. You have to hydrate them very well with a lot of salines. You're going to be running in a ton of saline with the drug to make sure they can stay well hydrated, the kidneys stay well perfused, and you try to flush that drug out as quickly as you can. Okay. Now, another drug that kind of fits into the same category as amphotericin B is going to be one called nystatin. This one is going to be better from a side effect standpoint because it actually does not get very well absorbed systemically. So nystatin ones can either be used topically, oftentimes either comes as like a cream or a powder. You can apply it to outside of the patient, or it can be used for oral candidiasis, so thrush. It's good because it actually doesn't get absorbed. So very good at killing the bacteria or the fungi, but does not get absorbed to cause systemic toxicity. And so we can give this to patients, really no problem. We give this to little kids, even though they swallow it, it's no problem because it won't get absorbed through the GI tract. But nystatin's another big one you're going to see used pretty commonly. This is another one that's available over the counter. You can buy this for things like diaper rash anytime. Okay, next we have flucytosine, and so basically this, as I mentioned, will cause DNA damage to the fungus by preventing that formation of thymidylate synthase. You can't form thymidine, can't incorporate that into new DNA. You'll see this being used oftentimes along with things like amphotericin B for a cryptococcal meningitis. As I mentioned, funguses tend to be harder to treat anyway, so imagine a meningitis with a fungus. That's pretty bad news, right? So oftentimes you'll use combinations of drugs in these cases to try to make sure you increase that kill for the funguses there. Not used too commonly, but you may see used sometimes as an additive drug to try to get better fungal kill here. As far as side effects go, you're going to find this is actually very close to a drug that we use for cancer patients as well. And so you can imagine, you know, really rapidly dividing cells tend to take a big hit when you have drugs that prevent DNA synthesis. So things like bone marrow suppression occur here. So again, we mentioned who's likely to get a fungal infection in the first place. Immunocompromised patients. Imagine we cause even more bone marrow suppression. Guess what? They can become even more immunocompromised. That can be a problem. Things like GI disturbances, rash. This one is available orally only. So again, if you have a patient who could not take oral drugs, that could be something that limits some of your therapy there. But again, not a great drug, mainly just due to the side effects here. And again, you're seeing that with less specificity for the fungus, you're seeing more toxicity for the people you're actually treating in this case, right? Other ones we have that we use pretty frequently are going to be including our imidazoles and triazoles. So these actually work to inhibit fungal CYP450 that leads to that conversion from lanosterol to ergosterol, which we mentioned gets incorporated into those cell membranes there. Now, as you might imagine, fungal CYP450, do you think there's any bleed over to human CYP450? I'm asking the question, so it should stand to reason that yes, there is. So this is actually really important from a drug interaction sort of standpoint here. We're going to see a lot of cross-reactivity here to where this will affect human CYP enzymes as well and lead to some pretty significant drug interactions as we're going to see here. Now, very frequently, you're going to see a lot of these triazoles and imidazoles being used for things like tinea pedis, tinea corporis, a lot of topical sort of skin fungal infections, the nails, things like that. These are going to use it very, very frequently in those cases there. The specific ones are going to include things like ketoconazole. This one tends to be an oral drug. Now, again, depending on how these drugs penetrate, you may or may not be able to use them for specific indications. This one doesn't enter the CNS, so that means if you were worried about a meningitis due to fungal infection, not going to be a good drug from that standpoint. A lot of these are available topically, which is good because, again, if I can just apply a drug topically, what does that mean as far as systemic exposure? Not much, right? Which means we're going to be limiting side effects, we're going to be limiting drug interactions. So again, if I were to say here, look, this inhibits CYP3A4, leading to significant drug interactions, but then on a test, for instance, I said, which one of these is most likely to cause an interaction with CYP3A4, and I put topical ketoconazole, you would automatically look at that and say, well, that would not cause an interaction because it's topical. It's not going to get absorbed. It shouldn't cause any significant drug interactions, right? So the route makes as big a difference as the drug itself does in a lot of cases, okay? Another one called itraconazole. Again, a lot of these tend to be orally active, and this one's actually starting to replace ketoconazole mainly due to its pretty wide range of activity against different types of fungus you're going to see there. Again, another inhibitor of CYP3A4, so you got to watch out for those drug interactions there. And then you're going to find that this is teratogenic. Anyone remember what that term means? It's not cause cancer. It'd be oncogenic if it was cancer-causing. Teratogenic means it causes damage to developing fetuses. So if you have a pregnant patient, you would not want to give this drug to them because it is teratogenic and cause birth defects in the fetus, okay? We'll talk more about that when we get into like the women's health section, the OB-GYN section a little bit later on, probably in Pharm 2, but we'll talk about teratogenesis there and why that's so important. I mean, obviously you guys can assume why it's so important, but we'll talk about some of the different aspects of it later on. Again, you typically want babies to come out normal, right? Best you can. Although I'm starting to question whether my kids are actually normal or not, especially my 2-year-old. I'm starting to see myself in her. I'm like, oh, you're going to be a weird kid, aren't you? I'm so sorry. So sorry. Anyway, some other ones, posaconazole. Again, a lot of these ones that you're seeing used systemically, you're actually finding these are very good for patients who are like neutropenic, those immunocompromised patients who have these invasive sort of fungal infections can be very good for that, right? So again, sometimes we'll use these for more like kind of refractory fungal infections or for those that have very severe sort of systemic infections. This one's kind of interesting because when it does prolong QT. So again, imagine if I had a patient who had immunocompromised or in the ICU, I have them on, say, fluoroquinolone for, gram-negative infection, and then I have them on this drug for a possible fungal infection. You can see now we have multiple drugs prolonging the QT interval that can lead them to potentially having torsades, right? So this is where things like checking the EKG occasionally can be useful, especially if they're having kind of electrolyte disturbances, which you can certainly see when you have things like hypokalemia, hypomagnesemia. So you gotta be careful for that, right? Monitor the labs when appropriate. Make sure you're looking at the EKG every once in a while just to see kind of where they're at, right? Next we have fluconazole. This is probably one of the most common antifungal drugs you're going to run across. Anyone ever heard of fluconazole or diflucan before? Most people have probably heard of it. This gets used very frequently for all sorts of different uses. As you'll see, it's very good oral absorption. It can penetrate the CNS, so this is actually good for things like cryptococcal meningitis. It can be sometimes preventative. We may give it a patient with AIDS-defining illnesses to try to prevent a cryptococcal meningitis from occurring here. This is good for candidiasis, both oral and vaginally. So again, depending on how you want to treat that infection, sometimes you can get away with using, again, more local sort of administration, right? So if I sometimes you'll see like diflucan vaginal tablets. We can actually apply that directly into the vagina to get good concentrations right there without having to worry about a lot of systemic exposure, right? So sometimes that dosage form can be very useful. As I mentioned, sometimes a single dose can just be used for vaginal candidiasis, which can be beneficial, from a compliance standpoint. But again, watch out. It can cause things like CYP3A4 inhibition. 2A4 probably not as clinically relevant, but the 3A4 for sure, it can be a big problem there. Okay, so you got to watch those interactions. Next we have the voriconazole. This is another oral one. This one is going to be, actually it's available IV as well, but it's actually kind of interesting is that normally the drug itself doesn't like to go into solution. This is, again, you don't need to know this for the test. I just find this interesting from a chemistry nerd sort of standpoint. But is anyone ever, you guys are familiar with the product Febreze? Most guys should be like, yeah, I use it. It's the only way I clean my room, right? I shouldn't let the cat out of the bag for the ladies in the room. Anyway, but basically Febreze is a cyclodextrin. Basically, it takes all the smelly smells and will just like kind of grab it up into this kind of this cyclical or cylindrical sort of molecule. And that's why actually the smell doesn't go away. It comes back once the cyclodextrin is gone. So again, you're just kind of masking the smell until it goes away. Well, we can actually do the same thing with drugs in these cases because voriconazole does not go into solution very well. We can put it into a cyclodextrin to get it into solution and then apply that to the patient IV to get good systemic exposure that way, right? So it's kind of cool using different carrier molecules in order to get the drug into the patient, right? Again, probably not interesting to you, but me, I thought it was kind of cool, right? Anyway, some other things. Look at these CYP enzyme inhibitions here, right? 2C19, 2C9, and 3A4. These are going to be very important from causing a drug interaction standpoint. Look this stuff up before prescribing. Those are the biggest things. And then again, watch out for vision changes. So again, alert the patient, hey, you can have things like changes in vision. If you notice any blindness, any dimming of vision, anything like that, you need to be aware of that to stop the medication, potentially come in and get something different. Right? Okay, now the topical agents, a lot of these are available over the counter, and so you can find these very frequently either being used for topical purposes. A lot of these are being used vaginally for things like vaginal candidiasis. Again, there's a lot of them that are out there. The three I'll ask about if I ask them on a test just because there's so many, and it's kind of, I think there's probably too many that are out there. But anyway, things like clotrimazole, miconazole, and teoconazole are probably the most common ones you're going to run into for the most part. And again, if you've ever heard of things like monostat, I'm sure you've seen commercials for it on TV at some point in your life, but these are things that are more commonly used for things like vaginal candidiasis. Again, they all have the same activity. Again, whenever you're using something topically, you typically don't have to worry about systemic exposure. You don't have to worry about having things like CYP interactions to worry about, right? So again, that could come up on a test question to look at the dosage form, look at the route, and see if that makes a difference. Up next, another good group of antifungals that are good for more like invasive sort of fungal infections are going to be the echinocandins. This includes caspofungin, micafungin, and anidulafungin. I had a friend in pharmacy school who was named Micah, and she said micafungin is my favorite drug in the world because of my name right in. So that was kind of cool. But anyway, so again, a couple of different ones here. These are actually working to, again, inhibit that cell wall formation. This is actually inhibiting this D-glucan synthase. And so if you have less D-glucan to put into the cell wall, decrease that integrity, break down this, the fungus there. Again, usually going to be used for more either resistant or more kind of invasive sort of fungal infections, especially in immunocompromised patients. Again, one thing to note, if you're ever looking at things like cultures and whatnot, with bacterial cultures, anyone know how long that usually takes to come back? 48, 72 hours. I mean, you can get a read on it initially just to see kind of what, if you see bacteria there, but if you're actually trying to grow it out, it can take a couple of days to really come back. Anyone know how long it takes for a fungal culture to come back? It can take weeks sometimes, right? So again, this is one of those things where if you suspect your patient has a fungal infection and you send off for a culture, do you want to wait a couple of weeks to get that results back before you initiate therapy? Not typically, your patient may be dead by then. So the case may be, you typically want to start empirically and kind of go with one of these big guns, and then once the cultures come back, then you can kind of scale back down to see if you can use something a little bit more narrow spectrum. But just know that usually fungal cultures take a long time to come back. Again, usually going to be pretty well tolerated for the most part, but again, you're going to see these electrolyte abnormalities. Things like hypomagnesemia, hypokalemia can be problematic, right? Especially if they have any kind of pre-existing heart condition, that can be a problem. Another one you're going to use pretty frequently if you're in the emergency room, urgent care sort of setting here is going to be griseofulvin. This is actually one of the ones I mentioned that inhibits those mitotic spindles and actually stop the cell division there, right? So they can't pull the DNA chromosomes apart. They can't really have full mitosis there. And this is good because it actually gets deposited into some of these skin precursors, things like hair cells, nail cells. So as you might imagine, these are very good for more kind of topical sort of fungal infections there, right? So you see these used for a lot of nail infections, a lot of tinea capitis, things like that. And again, treatment time is going to be pretty prolonged for these. So just to give you an example, if I'm doing things like scalp infections, at least a treatment time of 1 month. I mentioned it's hard enough to take a drug 1 time a day, hard enough to take antibiotics for 10 days straight. This can be very difficult from a compliance standpoint. Now imagine with your toenails, I'm going to take a drug up to 12 months straight. That can be very difficult from a compliance standpoint. So a lot of patients will start strong, have a weak finish, and then guess what happens to that infection? Comes right back, right? So maybe improve to some degree, but then it's going to come right back if they don't finish out the full course there. But again, needs a long time to treat. And again, this one's good. It's very lipid soluble, so it's able to get into and deposit into those precursor cells to really kind of get to the site of infection. Those that will not get Candida. And again, this tends to be more fungistatic, which is very similar to what we talk about as bacteriostatic. Won't really kill the cells off directly, but will prevent them from proliferating, right? That cell division. Probably, again, goes why it takes so long to treat a lot of those infections there. And for the most part, very well tolerated. This one's kind of unique because it does actually induce some of these enzyme systems, so 1A2 and the 2C family, right? So by inducing enzymes, what does that do to the levels of the affected drugs? It should decrease them, right? So you may see decreased efficacy out of other drugs this would affect. Okay, a couple other ones who have some of the allylamines. So again, these are working to inhibit ergosterol synthesis. This is where you're going to find some topical agents like Naftin, Lamisil. Again, these are going to be good for like nail infections and whatnot. Again, pretty long time to treat. Toenails, for whatever reason, farther away from the central blood supply, usually enclosed in a shoe, things like that. They tend to take a long time to treat, up to 12 months. Fingernails, maybe 6 to 12 weeks, but still compliance is going to be a big issue with these drugs. We also have Tolnaftate or Tinactin. Anyone know who this guy is? John Madden, right? Tough acting Tinactin. Anyone seen those commercials ever as a child? Okay, very few heads nodding, so I'm again showing my age. Again, Tinactin, another big one found over the counter. It can be used for a lot of these nail infections and whatnot. Used pretty frequently. So again, just kind of give you an idea of what kind of armamentarium you have available to you when treating these different types of fungal infections. Okay, and then real briefly, we have a couple of antihelminthics. What are these going to be good against? Worms. Antihelminthics mean worms, right? And again, you may think, well, how often am I going to treat worm infections? More often than you might think, especially in the ER and things like that. Especially little kids, they tend to get these worm infections. I'm hoping one day to get a nice, tapeworm infection. That way I don't have to worry about like dieting anymore. But until that takes place or takes hold, then I'll just stick with caloric restriction there. So anyway, so as far as antihelminthics go, two of the big ones you're going to run into include albendazole and then mebendazole. And so you're going to find that these actually work to, again, work against the microtubules within the worms themselves. And this will also help to block up glucose uptake and lead to the parasitic death, right? So it's really good for things like pinworms, roundworms, hookworms. Very good from that standpoint, especially pretty fast acting. A lot of these drugs, maybe 1-2 doses, and you're able to clear those worm infections very quickly, which is nice. Again, very well tolerated for the most part. Maybe have some hypersensitivity, very rarely, maybe rash. Could result in Stevens-Johnson's, but exceedingly rare. These can be used very safely for most patients. And then another one used pretty frequently is going to be pyrantyl pamoid or Pin-X. It's good for pinworms and hookworms. Again, this one's actually kind of interesting from a mechanism because it will release acetylcholine and inhibits cholinesterase. And so if you remember back to what happens if you have too much acetylcholine activity at the nicotinic receptor, what happens to the muscle? It gets overactivated initially, and then it will wear out, it will tire out, and then eventually you find paralysis and death. So basically, it causes little worms to fasciculate, and then they paralyze and they're dead, right? Then you can just pass them normally. So again, another one you may see out there occasionally. Again, another over-the-counter product you may find. Anyway, so that is it for the bugs and drugs section. Whew is right. Any questions from that? I'm going to try to start the ENT section real quick now, just see what I can get through. So let's go over to that.